Welcome, everybody. Thank you for joining me for this talk. It's a pleasure to be able to share this with you at this time. So I also want to thank Ares and Novoxel to have invited me to present this talk. And also he showed me how to do a virtual background. So you can see I had fun trying to create my background. Okay, so let's just have an hour of sharing from what I have learned about Tixel. So let's start with some financial declarations. I'm currently a key opinion leaders, one of the key opinion leaders of Lutronic Laser and Novoxel, who is the maker of Tixel. I was a past KOL for Alma Laser, Deca Laser, Galderma, and the Tixel company. I'm now the current medical director for Aztec Services in the UK. Aztec Services is the distributor of Novoxel products in the UK. And I must say that for this talk, I'm not being paid. It's just I'm doing it as a favor for Novoxel because we're all in lockdown. So there's nothing much for me to do anyway. So I thought I might as well use the time fruitfully to share what I have learned about the Tixel machine. So the agenda from today is we'll discuss about the consultation process, how to optimize the treatment process. We talk about pre-treatment skin preparations. We will talk about treatment process, how to do it. And then we'll talk about how we can up our Tixel treatment so that it can compare with fractional CO2 laser. And then we talk about post-treatment care, what I do, some complications that I've observed, and then some discussion about why I think the treatments so-called fails. And then we'll look at some clinical pictures, and then we have Q&A. So hopefully it will last about an hour. As an introduction, I'm sharing today my Tixel experience based on performing over 500 procedures. Novoxel told me that I have bought the most shots from them in the world. So basically they're saying that I have used Tixel more than everybody else in the world. I've done some clinical trials for Tixel. Some are unpublished and some will be published. And also I'm the medical director for Aztec Services in the UK, the distributor of Tixel. So I get all the complications and questions about Tixel from the UK. And also I've got some colleagues from all over the world who just WhatsApp me and ask me questions about Tixel when there's a need for that. So I'm going to share with you what I've learned from that. And I also run regular Tixel workshop in London. And what I'm going to share today is just some of the queries that some people have asked me during the lectures. So hopefully that will be helpful for everyone. But as this is an advanced Tixel talk, I'm not going to introduce what Tixel is and how it works. I would assume that all of you have used the Tixel, you know what it is. So I'm just going to share with you what I have done and modify from the protocol that was recommended. And how I have found it to be helpful to improve my clinical outcome. So let's start by defining what I mean by an optimized treatment. Optimized treatment for me is a treatment that can deliver the results that is satisfactory to the patients. So the patient is happy, and as a physician, I'm happy myself. A successful treatment, an optimized treatment, is one that is very pleasant for the patient. So the patient will enjoy the treatment and will come again repeatedly for future treatment. And also a successful optimized treatment is one that has a very minimum amount of complications. So hopefully this sharing will reveal to you how I can achieve all this. Optimized treatment does not mean that I have to use the most aggressive setting possible, because some patients has very little photo damage on their skin. So they only need light treatments to freshen up the skin, but still we can make it pleasant for them and deliver results that they want. even the opposite side is that even if you use the higher setting, if their skin and photo damage is more severe than what Tixel can achieve, patient can still be not satisfied. So therefore, it's important, hopefully from this sharing, you can learn what Tixel actually can achieve and what it cannot achieve, and how to combine it with other treatment to achieve a result that will be what the patient is looking for. So during the consultation process itself, first for medical process, exactly what the patient is looking for. It is important that we match the right indication to the Tixel treatment. So for example, if somebody is, has a very severe photo damage, and I tell them Tixel is going to be great for you, you're going to get everything sorted out, then that is not true. Patient will be unhappy, and the patient will not like the treatment of Tixel. And in the same way, if the patient has a light treatment, and then we has a light problem with their skin, an early sign of photo damage, and we use a severe Tixel setting, then they will upset the patient as well, because it'll give them a prolonged downtime, and that will give a bad outcome as well from the treatment. What I look out for during consultation is for melasma, because once I see melasma on the face, that tells me one thing, is that I cannot use a high setting on this patient, because the risk of creating post-inflammatory hyperpigmentation increases considerably once you notice melasma. If you want to treat melasma with high settings, you can, but just tell the patient that temporarily their melasma is going to get worse, and it will take time for it to get better again. For me, Tixel is good for everybody who seeks treatment for photo damage skin, and that can be very light setting for the younger patients or less photo damage skin, and then a more aggressive setting for somebody who has a more severe photo damage skin. And my normal consultation is that I will discuss with them neurotoxins, dermal fillers, and home care products. Usually that is all. But now that I have Tixel, Tixel is part of the package that I recommend to everybody as a complete treatment for the photo damage skin. During consultation, it's also important to know the patient's ability to take downtime or recovery period. Somebody who tells me that they're very busy and can only spend a weekend or even no downtime, then they will tell me that I can only use Tixel at the open channel settings, and then I will then counsel them appropriately as to what it can achieve. Downtime is also something that needs to be defined properly, because it has different meaning to everyone. Okay, so what I tell my patients by downtime is that you cannot put makeup on if it's a woman. It's not a clear skin afterwards where they can just go out without makeup, because one of the advantage of being a woman is that you can women can use makeup to cover up any blemishes on the skin, and therefore downtime for me is just not ability to use the makeup. So with Tixel, no matter how heavy the setting is, they can use makeup by day 5. That's my experience. Okay. And then we need to know from the patient as well their ability to tolerate discomfort during treatment. If they state that they are very sensitive, then I can only use light setting. If they state that they are quite stoic and be able to take a lot of discomfort, then I will recommend to them more aggressive Tixel setting. And then that will also tell me how much anesthesia I need to put on for these patients. And last but not least is the ability for patients to pay. There's no point recommending a course of Tixel treatment if we know the patient can only afford one treatment, for example, because they will be disappointed because Tixel is a course for most of the time, and therefore the ability to continue to progress on with the treatment is important as well. So for example, this woman, she's 82, 83, when she came to see me in November 2016. As you can see, she has a very severe photo damage with excess skin laxity on in the jowl area here. So for this patient, Tixel is good. You can tighten the skin, but is it going to make her look like a 30 years old woman again? The answer is no. So that needs to be explained to the patient. We can improve your skin, but you need then to be combined with fillers to create more volume, and it'll probably take several treatments as well. So this patient understood that, so we carry on to use the Tixel treatment 2 to 3 times a year, and this is what she looked like. So this is her after having the treatment at quite a strong setting. She had 14 millisecond 1000 micrometer protrusion. So that was after 2 days. And the picture on the top there is what the patient looked like before, and then she kept coming, and then this is what she looked like in February 2020. So you can see there's a great tightening to her jowl areas. The lines in the what is so-called the accordion lines has improved. The skin texture has improved. There's some volumizing around the perioral area, and all this can then be further improved with fillers if the patient want to. But she's very pleased. So you can see even a severe photo damage like this can be improved, but it just takes more time, and it's better if it's combined with either treatments such as fillers, and once our skin is tight enough, we can even do botulinum toxin on the upper face. For skin preparations, a lot of people ask me, do the patients need skin pre-treatment before Tixel treatment? My answer will be depends on the setting of the Tixel. For low setting, open channel settings, absolutely not. There is no PIH that I have noted from all my treatments with such low setting. And also the answer will depend on the patient Fitzpatrick skin types. If they're darker skin types, 4, 5, 6, that means the skin tan more easily. So they have the ability to produce pigments more easily than the skin type 1, 2, and 3. That will means if I'm using a higher setting, there's a chance that the skin can develop PIH, and therefore I would recommend some pre-skin treatments. I normally use a mixture of hydroquinone, hydrocortisone, and tretinoin. So there is a drug in the UK called Pigmenom, which I normally use, or you can use like the Obagi Nudum series to prepare the skin for about 8 to 12 weeks before the treatment, and that will reduce the incidence of PIH. For melasma, also I do not pre-prepare the skin because with low setting, the heat doesn't actually get to the epidermis. So, sorry, the heat doesn't get to the basal layer of the epidermis. So I will show you this graph here. This is a Tixel heat chart. The one in pink here is on the surface. So you can see within 1 millisecond, the temperature on the surface will reach 400 degrees right away. And then this is sustained for 8 milliseconds. So we know this is an 8 millisecond setting for the treatment. But as you can see that the blue line here is at 5 micron depth. The red line is at 10 micron depth. The green line is at 30 microns. And the bottom here, which you may have missed, is actually the 100 microns depth. We know that the epidermis generally is about 60 to 100 microns depth. So at that kind of depth, normally the temperature doesn't go up above 40, 42 degrees, and therefore the melanocytes that is on the base of the epidermis will not get heated up, and they will continue to not produce a lot of pigment, and therefore the Tixel is safe for melasma without the need for pretreatment. But for melasma patients, I do prescribe for them oral tranexamic acid for maintaining the pigment, because the tranexamic acid we know will prevent the formation of melanin on the skin. So they can take it continuously. The dose I normally give is 250 milligram twice a day. Some doctors do stop it at 3 months, but personally, I just carry on giving it to my patient for a year or two, non-stop. I've never had any problem. Obviously, you need to rule out clotting tendencies from the patient. If they have that, then there's a contraindications for the treatment. And now maybe in the COVID-19 season, the ability to clot more may not be desirable. So I do stop my patients now for tranexamic acid and told them that probably a melasma will come back, but it's safer if they do get COVID-19, because as we know, COVID-19 can increase coagulation in the blood. So that's melasma and skin preparations. Now, part of the pre-treatment preparation is photography. It's important that we take good photograph of patients. The minimum number of photograph I take per visit is 5. The top pictures here represents how I take the pictures. So one is a frontal pictures, and then do the left and right 45 degrees angle. And the way I standardize it is that the nose just about touching the cheek from on the photograph, so that the next time I take it again at 45 degrees angle, you get a standardized position. And then the other one is at complete 90 degrees. Make sure that the shoulder turn is not just a neck turning, because that will then stretch the skin around the neck, and they will give a distorted pictures. And I suggest taking it with a good high resolution photograph, because sometimes the improvement of Tixel, especially at low setting, is for fine lines. So it's nice to have the fine lines being shown before the treatment on the photograph, and therefore the after photograph will show the difference. Be careful when you're taking photograph, because a lot of camera now adjusts itself, so it's not the exposure are not set as a standard, and it adjusts itself depending on the lighting on the day, and that can interfere with your photograph. So sometimes the before photograph actually looks better, because some camera even has this smoothing effect on the skin, and such camera shouldn't be used for Tixel purposes. Photograph is also important, even if there is no good results at the end, or results that you cannot see, because most of the time with Tixel, actually the patients can feel the difference. They are very happy, but then photographically is not evidence. So that, as I say, can be due to the poor photography. But sometimes the improvement can be very minor. So then that is also give you a chance to talk to the patients, perhaps adding more treatments, sessions, or supplementing Tixel treatment with other treatments to achieve the goal that they want to achieve. The next thing I want to discuss is how to prepare the skin just prior to the Tixel treatment. There are two skin preparation that I use for Tixel. One is the hypochlorous solution that has just been introduced in the past few years. I really like this product because it's just like water. It's non-irritant to the skin. However, anything that is water-based will hydrate the skin. and the skin will then contains more water, and this will cool down the tip when it touches the skin, because the water will evaporate first at 400 degrees, and they will take away some of the heat, and therefore the severity of your treatment will be less. The depth of the penetration of the heat will be less. So have this in mind when you're doing this. So normally, if you do use water as a disinfectant, make sure you wipe it very dry at the end. I will actually sometimes put alcohol again, just to clean it very quickly, to try to evaporate some of the water so the skin will be drier. But if I'm going for a more aggressive setting or treatment for Tixel, I will only use isopropyl alcohol to clean the skin, because it will disinfect the skin and also dry up any moisture that are on the skin. So more heat will get inside, and then the treatment will be more aggressive. In terms of anesthesia, most of my patients do not need anesthesia if they're having treatment of 8 milliseconds or lower. Some of my patients can tolerate up to 14 milliseconds without anesthesia, but it is uncomfortable. So it's no point to push it to the patients that way, because comfort during treatment is important if you want the patients to come back. So my limit is about 8, maybe 10 milliseconds. Anything above that, I will put on topical anesthesia and put it in sufficient thickness, and I will leave it for about 20 minutes or so. What I will do is that when I remove the anesthesia, I remove it section at a time. So for example, I'm just going to do the cheek. So I will just remove the anesthesia in the cheek area, and then I'll treat that area as many passes as I want to. Once it's done, then I'll spray that with hypochlorous solution to cool it, and then I'll move on to the next section, and so on and so forth. Because if you remove your topical anesthesia all at the same time, then as you know, the topical anesthesia doesn't last very long. And if the treatment lasts about 30 minutes or so, by the time you come to the last bit, the patient will feel everything. So it's best to just remove it section at a time. Now, I found that if you're just using maybe 1 or 2 passes, topical anesthesia is sufficient. But once you're doing more than 2 passes, the heat can be too much, especially at high contact or dwell time settings. So for such patient, I actually do nerve block. So I just do very simple nerve block. Normally I do the infraorbitals nerve block and the mental nerve block. That will anesthetize about 2/3 of the face. The lateral side here, there's a preauricular nerve, but I don't inject that. What I do is I just put topical anesthesia. And the forehead, I'll put topical anesthesia as well. And around the eyes, I'll put topical anesthesia. This actually is a good way of anesthetizing the patient and saving time at the same time, because after I've done that, I just inject the infraorbital nerve, then I know the whole cheek area will be numb, and I can start to treat the patient immediately while I'm waiting for the other bit that is treated with topical anesthesia to get numb. I can start with the area that are numb by the nerve block first. And that's how I do mine. So I don't have to ask the patient to come any earlier than necessary. They just come in, sit down. Once all the documentations are ready, I'll put the topical anesthesia on the forehead, around the eyes, and on the peripheries. And then I inject the nerve block, and I can start treating the patient right away. Okay, that's how I do my anesthesia. Okay, for the treatment itself, you need to predetermine beforehand what settings you want to do or what you want to achieve with Tixel. In terms of protrusion, I always set it at the maximum. So if your machine has 1,000 micrometers settings, I go for that. And if you do use Mesotex or Tixel Compact, Tixel C, then the maximum protrusion is only 800. Then just use that. My thinking is that because Tixel transfer the heat energy by conduction, therefore we want that to be constant all the time, and therefore I always set the protrusion to be maximum, and all I adjust after that is just the dwell time. So that makes the treatment less complicated for me and also for all my staff. I just tell them my instruction for them just what dwell time to use, because they will know that the protrusion will always be at maximum. My guidelines, if you want to know, is to reduce the incidence of PIH. As I've said before, Fitzpatrick skin type 1 to 3, I can go up to 14, even 16 millisecond if you want to. And then for skin type 4 to 6, I found that if you do up to 10 millisecond, it's usually not a problem. Yes, for increasing the comfort of the treatment, what I found is that if you actually press the tip into the skin more firmly, that will create a distraction on the skin. So when the Tixel tip touch the skin, it's actually less painful. You can try this yourself. One way you just lightly touch it on the skin, and another one way you actually press it into the skin. And you will find that when you press it into the skin, you feel that it's a lot less painful than if you just lightly touching the skin. So I would advise everyone to push the treatment tips strongly into the skin. And I also let my patient have handheld electric fans that they can use to cool themselves. I think that's very helpful, because patients get very distracted with this fan. So they are focusing more on cooling their skin rather than on the heat that's going on their skin. And sometimes I even give them 2 fans to hold on themselves. If you ask somebody else to hold the fan, then the patient's again just focusing on the pain. So do give them the handheld electric fan, and they'll give them something to think about. That's my tip. Now we are going to talk about how we can use the Tixel treatment for a more aggressive fractional resurfacing, so that it's comparable to CO2 laser. So as we know, there are a lot of similarities between Tixel and fractional CO2 lasers. As this picture shows, the pattern on the skin is very similar. Both create micro dots on the skin in a pattern. Now with CO2 laser, when you're doing the treatment, what is important is there are 2 important parameters that need to be set. Is you need to know the depth of ablation of your CO2 laser, and also the density of the treatment. So here's just an example of one of the CO2 laser, Lummex AccuPulse, which is one of the best in the market. This is a graph that indicates the depth of ablation from the CO2 laser against the amount of energy that is set on the machine. So the maximum is 170 millijoules, and they'll get you to 200 microns depth. And I can tell you from experience that there are very few doctors who will use 170 millijoules in their setting. Most doctors that I know of will set it below 100. So they'll get about 80 microns depth, okay? But the potential is that if you do use 170 millijoule setting in your CO2 laser, you can get up to 200 microns depth of penetration. So remember that number. Now with CO2 laser as well, the benefit of CO2 is that you can adjust the density of the treatment very easily. You just need to dial it, and then the scanner and the CO2 will adjust the spacing in between the dots, and you get more dots per pass. And to get good results, normally CO2 laser will go for about 40 to 60% treatment density. Now the question is, what is the depth of ablation and density of Tixel? Okay, so now that we have these numbers, we can then try to match our treatment to Tixel treatment to CO2 laser. We know the depth is not an issue because the depth of Tixel will easily match CO2. What matters now is just the treatment density. And as I said, laser normally you aim for about 40 to 60%. This is what I try to achieve when I'm going to do more aggressive Tixel resurfacing. But for general treatment, to achieve a good result with just one treatment, I suggest going for at least 20% density. So if you're using about 6 microsecond, which is about 4% density or 5% density, then go around the face or whichever area you want to treat for at least 4 passes. If you just use 1 or 2 passes, in my opinion, the density is too low and you will not get the results that is noticeable on photograph or the naked eyes. The patient will of course feel it, even 1 or 2 treatment, but I think if you can bring it up to about 20%, the result will be better. But again, as I said, match it to your patient's expectation. If they don't want any downtime and they have very low photo damage problem, then just do 1 or 2 passes as you normally do, and then you can then supplement it with some of the mesotherapy products, and that will perhaps be enough for such patient. Okay, I'm not saying that everybody have to use this high setting. Now the next question is, how do we enhance the Tixel heat penetration to make it even more aggressive? As we know, CO2 laser, you can have the deep FX, for example, where you can go a lot deeper than just 200 microns. So let's think about Tixel, how we can actually enhance the Tixel heat penetration. And now, what I've learned from this graph is that on the left here, if you see the picture here, the green here is 30 microns, okay? So you can see that most of the heat is in the first 30 microns of the epidermis. And when you go to the base of the epidermis, the heat is actually not that much. So we know that the first 30 microns of the epidermis is actually the stratum corneum. Most skin will have at least 10 microns of stratum corneum, which is this, and some areas of the body can have up to 30 microns of stratum corneum. Okay, so basically what this graph shows us or tells me is that most of the heat is taken up by the stratum corneum. So you can see the animation, no, the illustration here on the right. The tip is 400 degrees. Where it touched the skin immediately is 400 degrees. But as it goes down, it cools into this blue area here. So obviously now, if we want to push the heat deeper into the skin, the best thing is obviously to remove the stratum corneum, because if you have no more stratum corneum, then the tip will then touch the dermis right away, and then you have a much deeper treatment. Okay, so this is the histology from the pig study. So you can see that actually the stratum corneum after the treatment, even at 16 milliseconds, is still there. It's just compacted and desiccated, but it's still there. At 12 milliseconds, it's compacted, but it's still there. And obviously at 6 milliseconds, there's hardly any disturbance to the epidermis, just a light coagulation under the skin. This is another illustration of what we think the epidermis look like. So you can see the epidermis is just desiccated, but it's still there. So this is different from CO2 laser, where actually the whole epidermis is evaporated. Whereas with Tixel, you're just desiccating the epidermis. This is important, obviously, because when it's not completely evaporated, then some of the viable cells can still reproduce and therefore make the treatment to heal faster. That is the advantage of Tixel. But if now we want to match with CO2, we want to remove the epidermis, so the healing time is probably more similar to CO2, but the results will be also a lot closer to CO2 laser. So the other thing that the histology study shows is that after the treatment, you get the desiccation of the epidermis, but you also create this vacuolization. This is the epidermis to the dermis has split. And therefore, the dermal epidermal junction is weakened. And if there are multiple of this along the skin, then we know that the epidermis is going to be detached very quickly or very easily, okay? So if you increase the density of the treatment, so you say you do 2 or 3 passes with Tixel first, they will create a lot of these vacuoles and split in the dermal epidermal junction. And all I have to do is then to just soak it with water so that those epidermis that are desiccated is slightly moist. And then I then use a gauze. This is an 8 or 12 ply gauze, very rough. And then I soak it in normal saline, not normal saline, sorry, hypochlorous solution, because normal saline, if you spray on the skin, is on post-Tixel is quite painful. So use hypochlorous solution. I just spray it onto the gauze and then just gently wipe it off. And you can see the epidermis or stratum corneum will start to come off. How much come off will depend obviously on how many passes you have put on and also on how hard you abrade the skin with the gauze. And once the epidermis has been thinned or removed, the next treatment will then actually be mostly into the dermis. This is actually very nice if you want to see a dermal contraction, which I love when I was doing CO2 laser, because you can start to see the skin just contract as you treat it, okay? But of course, there's a lot of advantage of Tixel over CO2 in that it doesn't create fume. The treatment is less painful still, even at this aggressiveness. So it's a lot easier to do for me than if I were to use CO2 laser. Well, not to mention that CO2 laser is a lot more expensive to buy as well and maintain compared to Tixel. So here is a clinical example. This is a patient who came to me with severe acne scarring. What I did was to treat her with 14 milliseconds, and as usual, I use a maximum protrusion. I did 3 passes first, so round and round and round 3 times. And after 3 times at 14 milliseconds, I know the skin is quite loose. And then I use the wet gauze, which is wet with hypochlorous solution, give it a firm wipe. And then after that, I do another 2 passes to see the dermal tightening. But I set it at lower because without the stratum corneum, most of the heat will go straight to the dermis, and we really don't want to put too high. I've done it up to 14 milliseconds, it's safe, but the healing is slow. So I suggest maybe 8-10 milliseconds once the epidermis has been removed, and that's safe enough in my opinion, okay? So this is what she looked like. So you can see she's a skin type 6, actually. It's a very dark Indian lady. As you can see, the pigments that are on the skin, which is in the epidermis, has been removed. So you can see that the skin is pink because, you know, beyond the epidermis, everybody is of the same color. And that's what she looked like. And the bit where there is pitting from the scars, because the Tixel tip couldn't get in there, so the dermal epidermal junction is still tight, and therefore it's not easy to remove. The epidermis is still there. And this bit here where there is bleeding, then we know for sure that this is actually the dermis, okay? Where there's no bleeding here, you can still see probably the bottom of the epidermis, but once you see bleeding, you know you are into the dermis already, okay? So everybody think, wow, this is crazy. So I'm going to show you how she healed later on, okay? So stay on this talk and I'll show you how she heals, but I'm going to move on from this topic now. We're going to talk about post-treatment care. Post-treatment care will depend on how severe your treatment is. If you just use the open channel, easy peasy. So you do the open channel treatment at 5, 6, maybe 8 millisecond setting. And after that, you just put your mesotherapy products so that they can get into the skin, your vitamin C, your antioxidants, whatever you want to put on the skin, okay? But as we know from previous studies is that the things that get into the skin are things that are in liquid form. If it's in a cream form or gel form, then they actually sit on the skin, and the amount of penetration is actually no change or even less sometimes, because the osmotic pressure is higher in the gel, so it actually draws water out instead of putting the products in. So when you want to apply open channel products, they must be in liquid form, okay, and not too high concentration, so the gradient will not pull the water out of the skin, but actually push products into the skin. The other thing is, do not apply cosmetic products that are meant to be sitting just on top of the skin, because some therapies I saw is that after the open channel treatment, they put products that are designed to be applied only on the skin. Why? The reason is because this product has preservative. It's only meant to be sitting on the skin. And this preservative, even though the concentration is quite low, but now if you have enhanced penetration of these products and they get into the skin, you can get contact dermatitis. This is one of the complications that I will discuss later. So be aware of that. For open channel, only use products that are meant to go into the skin, okay? So mesotherapy products are perfect for such thing, for such treatment. If you're going for the ablative treatment, so 10, 12, 14, 16 millisecond, after the treatment, I don't bother with the mesotherapy products anymore. You just cool the skin immediately with hypochlorous solution to sterilize it. And then I apply Cetaphil lotion here, not the cream. The cream is too thick, so the lotion is perfect for patient's comfort, in my opinion. A lot of other people will want to use your own favorite post-treatment care. Yes, of course you may, it's up to you. But all I can say is that after 500 treatments, I use Cetaphil. I have no problems with it, okay? Whereas I do get sent pictures of patient getting contact dermatitis type of reactions after they use other preparations. So I can recommend Cetaphil because I've used it for 500 treatments, or maybe 600 now, and it's still no problem with it at all whatsoever. Now, when you're going for the more aggressive treatment, which is the one when you actually do 2-3 passes, abrade it, and then do more Tixel. So this is now like a proper CO2 treatment. The next day you get the serum coming out, the yellow fluid, and you really need to moisturize the skin a lot more intensively than the lower treatment. So for that, I will recommend Vaseline. So again, after the treatment, straight away, I cool the skin with hypochlorous solution that will sterilize it very nicely. And then I will apply the petroleum jelly on top, and then I'll give the tub to the patient, tell them to use it at least 3 times a day for the next 2 weeks. This is very important. Whereas if the lighter treatment, maybe 10 days with Cetaphil is enough. And it is very important that patients are told to avoid the sun for at least 3 months and more if you're a darker skinned individual. This is to prevent the PIH from forming. And very importantly, post-treatment is do give your social media contact details to your patient, okay? Because they will want to contact you and send you pictures and ask you, is this okay, doctor? Especially when you do the higher setting. So I always give out my WhatsApp contact number, and in the evening or whenever I'm free, I always check my WhatsApp more than emails or anything, because it's a lot easier. And then patient can also send their pictures a lot easier as well with such things. So use whatever social media you use in your country to be in touch with your patient. This also optimize the treatment, show the patient that you care, take away their worries. So if there's any questions, they'll come to you first, especially when you're doing the more severe treatment. Otherwise, they will go to A&E, and then that will create more problem for you. Tixel complications, I did an audit of my first 150 patients. This is in the first 18 months when I got my machines. So out of the 150 patients, we did 324 treatments. So on average, one patient get about 2 points something treatments. Out of this number of treatments, this is about, I think we use over 154,000 pulses or something like that. There were only 4 mild complications that I saw. There's 2 cases of PIH, 1 case of contact dermatitis, and 1 case of impetigo. What I don't count as complication is microcrusting, that is expected, and also edema. So this is not a complication. I always explain to the patient, you will get microcrusting, you will get swelling after this treatment. So tell that to the patients before the treatment, because if you don't, when they send it to you in your WhatsApp, then that suddenly become a complication, okay? So do tell them in advance. So let's look at these complications. So first of all is PIH. It can happen. In my case, there were only 2. As you can see, this is not my patient, but this is somebody that sent it to me. So this is perioral hyperpigmentation. The treatment is easy. I normally don't treat them at all. They will settle down by itself. Just ask them to use cosmetic. There was a man, a French man actually, who came to see me in London. He has some PIH around his eyes afterwards. So for him, I do treat it with topical depigmentary agents. I think I prescribed for him Cispera at that time to use it just 15 minutes every day. And after about 4 weeks, it clears up and he's happy. Okay, but obviously you can use whatever depigmentary agents that you have in your countries to treat this as the PIH. So it's not an issue, but most of the time, if they wear makeup, just tell them leave it alone. It will settle down. Contact dermatitis, as I said, this can happen because after the treatment, patient or some therapists actually ask patients to use other things other than Cetaphil, okay? So then they come back and say that their skin is inflamed even after several days. So this is my patient. She contacted me on day 5 and said, is it normal? My skin is still so red when you told me that the redness will only be for about 24 hours or so. So I said, send me your photos. This is what she sent me. So you can see clearly the pattern of the Tixel and the microcrust is still there, but the base shouldn't be red like this, okay? Normally it should be just little brown dots on the skin. When it's red like this, this is a contact dermatitis. So then I found out that she has been applying some creams, even expensive creams that she has bought herself, thinking that now the skin is more permeous to products. This is the best time to use all these expensive products. It is actually the worst because not only are the ingredients probably going in more, but the preservatives are going in more, and you can get this allergic contact dermatitis. For treatment, again, it's very easy because I told her your skin is very angry, so don't put anything on the skin. Wash off everything with normal saline and just put a normal saline compress to cool it down, and do not apply anything. Do not apply steroids because steroids will come down the skin and that will then make your treatment become of no use, okay? Because Tixel is to create inflammation on the skin. So do not try to calm down the inflammation on the skin. All you need to do is just ask them to use normal saline, cold normal saline to compress it, and don't put anything else on the skin, not even Cetaphil, nothing. And the next day, the redness will settle down by itself. The skin will start to form flakes. They look very dry, and just tell them to just keep using just a normal saline for a week, and it will clear. It's not an issue. So don't need to put anything other than cold normal saline. That's my advice. Impetigo can happen. That's why now, after the treatment, I'll spray the skin with hypochlorous solution. And since I've been doing that, I have no impetigo cases at all. And tell obviously the patient to keep this area sterile. or clean and don't touch it unnecessarily. So this is an example of impetigo. This is not my patient, but this is somebody sent me these pictures, but you can see the yellow pus under the skin, and they're like satellite lesions as well. So you know this is impetigo. If you do see this, the treatment is not difficult as well. Just ask them to get something like a Dettol cream, TCP cream or something like that from the supermarket to apply it 2-3 times a day, and it will heal up by itself. But if it's not, bring them into your clinic. You can wipe it down with some alcohol or hypochlorous solution, and then just apply some topical antibiotics like mupirocin or polymyxin. Okay, that's quite easy to do. Now, as I said earlier on, edema and microcrust are common and it should be expected at high settings, so it is not a complication. So you can see this lady after treatment, she gets severe swelling around her eyes and the microcrust. These are pictures I show to the patient. This is what you can look like when you go for high settings. This is normal, nothing to worry about. But as I said, give your social contact details to your patient. No matter what you tell them, they will still be worried. Okay, so everybody without fail will send me their photos the next day when I do severe treatments like this. Now let's talk about reasons that I can think of why treatment so-called fail. Okay, the worst one I think is weight loss, diet. So patients who are about to get married, about to have a family reunion, or reunion with the school, something like that. They want to look their best, so they come and seek treatment, and then they try to lose weight at the same time. If patients are trying to lose weight, then I can tell you your treatment will so-called fail, because even though the skin is tightened, but if you lost volume on the face, they will always look worse or not much better after the treatment. Okay, so like this lady on the right here, so you can see there's really not much different before and after 2 sessions. Other things that can make the treatment to be not obvious is obviously the treatment was too gentle. The setting like this 8 in 1,000 for this lady. So in the 2 treatments is not sufficient. So she will need maybe around 6 to get the noticeable results. Other things that is possible that can make the treatment less impressive is if they are on poor diet. Again, so this is quite controversial to say that vegetarian or vegan diet will give you bad Tixel result. It's not everybody. Most vegan and vegetarian person know how to balance their diet, so they make sure that they have enough protein. But there are some who just into it, they are not used to it, they're not eating enough protein, they don't have enough nutrients, and I find such diet is not good, and the result is not optimal. So this is something to ask your patients if your result is not good. Other thing is retinoids. For some reason, a lot of people, a lot of the therapists that I've trained and physicians, they like to prescribe retinoids after Tixel. It is of course good. Retinoids will improve the collagen production, but as you know, one of the side effects of retinoids is dry skin. And with the enhanced penetration initially as well, you get the dermatitis kind of look on the skin all the time. So when you review the patient at 6 weeks or 8 weeks, the skin still look very dry, full of flakes and a lot of fine lines, and therefore the photograph before and after will not look much different, and sometimes it can even look worse. So personally, I do not prescribe retinoids. I want the skin not to be flaky. I want the skin to be nice and smooth and shining. So that's why I don't recommend retinoids after Tixel. Okay, maybe when you have stopped the Tixel 3 months later, once you got all your photograph done, you can start them on the retinoids. Afterwards, that is up to you. Other reason is the sessions is just too few, so it's just not enough sessions that the patient has gone through. Even though you tell patient you need 6, some patients still come back after 2 and say, I can't see anything, doc. You just have to tell patients, you've got to wait. You know, it is a course of treatment. Other possible problem is using topicals to calm the inflammation post-treatment. As I said earlier on, no matter what you do not prescribe steroids. But some patients, when they see their face swell up, they will put aloe vera gel, jojoba cream to try to calm down the inflammation. And this is something that is not good, because obviously we want the inflammation, because this is what drives the new collagen production. So if you calm the skin down too much, then you will not get the result that is meant to do. Okay, and obviously somebody who is very severe photo damage, very thin dermis and epidermis, these are skin mostly in elderly, more older patients or elderly, or those that are in the sun too much. This type of skin are already very bad at forming new collagen. So you need to tell the patient realistically, this type of skin will need more sessions, more severe settings, so that you can get the results that you want. And you probably need to combine it with other treatments as well. So those are the things that I've noticed that can cause the result to be suboptimal in Tixel. This is another example that I have. Is a very nice Welsh lady. She's, as you can see, very fast skin before, with clear pupils, light Celtic skin, but she's a farmer, so she's in the sun quite a lot, and you can see that she has quite a severe photo damage skin. So I treated her with aggressive setting, 14 millisecond contact times for 3 treatments. She's very pleased with the results. She said her skin has improved a lot. She feels that it's thicker and give her more confidence. But then when I took her photograph, as you can see, there are some areas that has improved, like around the eyes. You can see the lines has improved, but the other areas that are actually worse. I mean, the texture of the skin has certainly improved. The skin look clearer, but as you can see now, she has a brow ptosis, and this accordion lines here is deeper than before. The oral oral commission lines has gone deeper as well. So what happened is she has lost weight. She has lost a lot of weight. And you can see now the temple is starting to sunken. The mid-cheek volume here has decreased, and therefore the skin is deflated. And therefore the lines in the bottom half of the face is worsened, despite the lower area becoming better. But because the temple fat is gone as well, the brow has dropped as well. So that's the reason. Okay, so if you just explain to the patient, look, she's very happy, so I just told her that all you need to do is just put back the weight that you had before. But if you don't want to do that, then we can actually put dermal fillers to try to recreate the fat that she had lost. So I did that. She didn't want to put on the weight back on, so I put fillers, and she was happy. She was happy beforehand anyway, but I wasn't happy because I don't see a good improvement there. But after the fillers, we are both happy. Okay, so that's all the theoretical bit. So let's look at some of the photographs. So this is patient recovery photos, which I'm sure everybody is curious about, with the deep setting that I use. So this is the first patients that we saw before. So this is a skin after the 3 passes at 14 millisecond before abrasion, and this is after abrasion. You can see the pigment has been removed, so you know you're looking at the deep epidermis or even dermis in some area. Okay, and then after this, then I do another 2 passes at 8/1000. So let's see how she heals. This is the other side, the same. And this is her the next morning. So obviously you expect something if you do this sort of severe therapy. You will get photograph from patients. So this is what I got. Is this normal, doctor? So yes, it's normal. The skin is swollen as expected. And you get this yellow serum that comes out from the skin. It will dry up and form crust. So I told my patient to just wash it off in the shower. not to jet it, but just to wash it off gently so the skin is clean, and then apply a thick layer of Vaseline. Again, try not to touch it too much. And this is the same morning, couple of hours later, after she had a shower. So you can see the yellow serum has been removed, and you can now see the epidermis starting to create some kind of repair here after 24 hours. Okay, you can start to see islands of keratin here being formed. This day 1 and day 2, better again. So there's more healing. You can see the Tixel pattern still here. I didn't abrade everywhere because her problem is only in the cheek and the temple. So there's no need to treat everywhere else. She came in for acne scar treatment. Now, interestingly, on day 2, she developed milia, this white dot here. This is quite normal because when the skin is healing, it's producing a lot of keratin, and then you put Vaseline on top, they get trapped and they form milias like this. Don't have to worry about it, just let it heal, and the body will usually push it up along the epidermis, and it'll be cleared at the end. If it has all healed up and you still see 1 or 2 milias, then just use a needle, prick it out, and express it, and that's the end of it. So I told her, before even she mentioned the milia, I said, look at the white spot, those are milias, don't worry about it, they're not infection. Okay, so day 3, again, you can see the skin start to dry up and healing up very nicely. Day 4, you can clearly see the keratin islands starting to be developed in the top of the face. But to my horror, she said, oh, I got called in to go to work. She's a doctor, a GP, so she has to go back to work. There's nobody to take care of her shift. So, okay, reluctantly, I said, okay, just put on a lot of Vaseline and then put mineral makeup on top. For skin like this, I always recommend mineral makeup because they are large molecule stuff, so the chance of them getting into the skin is less. Okay, when I say mineral makeup, you must make sure that it is 100% mineral makeup. So there's a few brands in the UK. You can see what is available in your own countries that has mineral makeup, because the word mineral makeup doesn't mean that it's 100% mineral makeup. Some only have 5% or 10%. There is no legal qualification as to how many percent of mineral there is to be called mineral makeup. But when I say mineral makeup here, I make sure that they get the 100% mineral makeup. So there is nothing that can get into the skin. So that's what she did. She just put Vaseline and then put the mineral makeup to cover it up, and gone back to work on day 5. Okay, and this is her day 6. It has healed up very nicely. Most of the epidermis has been formed, but it's not the matured epidermis yet. But at this stage, you can start to see the post-inflammatory hypopigmentation, which is common when you treat darker skinned individuals, because the melanocytes hasn't produced the melanin yet. So they end up whiter compared to the treated area is whiter compared to the non-treated area. This is quite normal. But the nice thing about fractional treatment is that you always leave islands of melanocytes. This will then create pigments in the future, and it will fill up everything back to normal. Okay. Now, why I treat this dark skin patient so severely was because she was very upset with her scarring. The scars, she tried to cover up with makeup, but the makeup is not able to cover the scars completely. So I told her, we can go and do this severe treatment, but your skin color will not match initially, maybe for up to a year. She said, I don't care about that. As long as it can look good under makeup, that's what I want. So that's why I can do this on a type 6 patient, because the skin will not match completely probably for 6 to 12 months after treatment. Okay, so this is an exceptional case where the patient is willing to use makeup continuously even after the treatment. So this is her on day 8. It all has healed up nicely, as you can see. Just the areas of hypopigmentation And she's very happy. So let's compare. This is her before and after. So I'm going to leave this for a few minutes, for a few seconds for you, so you can see the severity of the acne scars. And this is her afterwards. Just one treatment, okay? This is what we can achieve if you remove the epidermis and then you apply the Tixel directly to the dermis. You get a dermal contraction. You can get this sort of result with just one treatment. And she is so delighted, so happy. She don't care about this hypopigmentation because now she can use makeup and it will cover it very nice. And she's already asking me, when can I have my second treatment, doc? So when you do treatment as severe as this, I suggest at least 3 months break in between treatments so that the skin have the chance to heal properly. And I want to see some of the pigments return more before I do the treatments for her again. I haven't seen her again because we've been in lockdown since 23rd of March. But she's very keen. She's really texting me and asking me when she can have her next treatment because she's very pleased with the results. This is also very interesting. You can see she has this dermatosis papulosa nigra, DPN, on her face, and with such aggressive treatment, when I removed the epidermis, actually they're gone. I managed to remove the DPN as well. So you can see there's no DPN on the surface. On here as well, you can see. So it's just one of those things that on the epidermis that can be removed when you wipe off the epidermis. Okay, very interesting for me. This is another example when I do Tixel at 14-1000, only 2 passes this time around the eyes, and then I abrade it. So you can see the abrasion here. This is severe. I don't recommend this for everybody, but these patients want to have a fast, quick improvement with just one treatment. So he was fine until day 5, and he said, my skin around the eyes has some pus on it. Can you look at it for me? So he sent me his pictures, and this is what he looks like. So of course, the first thing that comes to mind Tigo. They have a edit. You can see the appearance still yellow. There's not much satellite lesion. The background is actually non-inflamed. They're not so red. So what this is actually, he hasn't been washing his face. So this is a buildup of keratin on the skin as the skin sloughed off during the healing process. They all just packed tightly like this. Same on the other side as well. You can see these are just packed keratin debris on the skin that hasn't been washed. So when you see this, not a problem. I just told the patient, just go and have a shower, jet around your eyes, because this is already day 5, so we know most of the epidermis would have been healed up. And that's what he did. And then he sent me his pictures on day 6, and that's what he looked like. So not a problem. So don't panic when you see such thing. This is another patient, another man. You can see he just don't like this baggy eyes and the droopy eyelids. So he wanted some non-surgical treatment. So I said, okay, let's do Tixel, but for this, we need the aggressive one. There's no point to do light treatment for this. You'll not achieve anything. What you want is a full dermal contraction, so the skin can be tightened. So I did 14-1000, 2 passes again with abrasion. And then after that, this is a strong one. I put 14 millisecond again to see what happened, okay? But to me, I think it's too much now. After I've done this to a few patients, the swelling is a lot. So I suggest after you remove the epidermis, just go for 8 or 10 millisecond maximum, okay? But this is what he looks like. So he sent me these pictures the next day. Is this normal, doc? I said, absolutely. The eyes always swell, just his swelling is more severe than usual, but there's no sign of infection. You can see the eyes is white, there's no conjunctivitis. So don't worry about it. Send me another pictures tomorrow, the next day. So this is what he did. So the next day, the swelling settled down considerably. Just some crusting left behind. So I told him this is too dry. So you can see here where I have treated. So normally for around the eyes, I do treat above the brow. So some of the skin here will contract and pull the brow up. And then I treat the upper lid and lower lid up to about mid-cheek area here. So I told him to use Vaseline to make it not look so dry. He never listened. It's still very dry at day 3, but you can see it's still is healing well. Day 4 is dry, but it's still healing well. Day 5, most of the crust has fallen off. The redness has reduced. Day 6 is still red, some crusting. Day 7, much better again. Day 8, practically healed, just left some flakiness, which happened as the skin continued to heal. It continues to chuck a lot of stratum corneum, keratin, sorry. And by day 10, the flakiness is gone, just red. So you can use a tinted moisturizer to cover that up. By day 11, it's better. By day 14, he's a happy guy. And now you can see just one treatment. This is in July last year when he came for his consultation, and this is about 14 days after his treatment. So you can see this very good tightening under the eyes here on both sides, and you can see the upper brows as well. You can see the nice contraction of the top lid there as well. Okay, so that's it. This is a very lovely volunteers actually. She's a nurse in the UK who actually practice aesthetics. So she is a Tixel user herself, but she volunteered to be one of the model during our training in London, and she has kindly allowed me to show her photograph to everyone in the full face without having to just section off the area, so you can see what it looks like healing on the full face. So thank you very much to this lady who is probably also listening to this talk. Okay, so this is her immediately before treatment. I took the pictures, and then this is her. What I did was to use just 12 1000 3 passes, but I did the right side, which is this side, and the left side is a hands-on training, so the delegates treated her left side. Okay, I'm more aggressive, so I do abrade the skin more, so you can see that when she goes home, there is more serum coming out from the side that I treat. You can see more serum here drying up on the side that I treat as compared to the delegates. So they're new at it, they're still a bit worried, so they don't really give it a good go. And also the Tixel is not being pressed tightly on the skin, so there's less inflammation on the side treated by the delegates as well. So it's important. You can see the difference between how I do it and how somebody who is new or newish does it. This is day 1. So you can see, again, my side is more crusty than the other side. Patient was a bit worried at this stage because she feels that now the right side is pulling back more than the less treated side. I said, don't worry, it's probably just more swelling. It will all balance up in the end. This is day 2. She's healing quite nicely. Day 3, drying up. Day 4, the crust you can see more on the side that I do compared to the other side. Day 5, better again. Day 6, day 7. By day 8, you can see it's all healed up, so no more crusting, and she can actually use makeup and go out and enjoy her normal social life again. By day 9, the redness is starting to settle, and this is day 21, the last pictures that I got from her, where most of the redness has settled. But at the deep setting, okay, I can tell you that the erythema will carry on for at least 3 months. Okay, so that is to be told to the patients. Don't expect the erythema to settle down quickly. just use makeup continuously if you want to cover that up. Not severe erythema, but it's still there. And this is before and after, so you can see this patient before, and this is just after one treatment. You can see the commissure, oral commissure here has been pulled up very nicely. The crepiness under the eyes has improved quite a lot. These deep lines in between the eyes improve as well. So she's very pleased coming for second treatment. But again, because she's a slim lady, she will need some filling to be put maybe in the upper cheek, and maybe a bit on the oral commissures here and on the jowl area, just to give her more youthful and younger looking skin. So that's one treatment. This here is before, a few more before and after photograph very quickly. So this is a study that we did using the Vizia. So you can see this nice improvement. So this patient in the wrinkles was before, he's pretty good at 87% of the percentile, but after treatment, he's now in the top 95% percentile with this new skin. And again, epidermal lesions such as this flat seborrheic keratosis, when you do it 2-3 passes and then use a gauze to abrade it, they're gone. Okay, you can remove it that way. So just do a few passes around these areas until they're practically detached, and then you just wipe it with a gauze and it's gone. Okay, this is another nice lady, and you can see she's actually quite bad before the treatment. Among her age group, in her wrinkles, she's at the bottom 30% of the percentile. After treatment, it's much better. She can obviously be better again, but it's much better. So she has improved from the bottom 30% of her age group in terms of wrinkles up to 64% after the treatment. So this is a 6-month study. She had 3 treatments at 14,000 once a month, and then this is 3 months after the last treatment. This is her true age using the Vizia. So her actual age was 45, but the machine said at the start that she actually looks like a 53 years old. So she was obviously quite upset at that. But this is her after the treatment. So 6 months later, she's 46 years old, but her true age has come down to 47 from 53. So she's very, very pleased with that improvement. This is another lady. Now this one is the opposite end. She's actually very good for her age. She's in the 78% percentile before the start of the treatment, and at the end of the treatment, she is actually at the 88% of percentile. We can see the improvement to her lines. What I found with Vizia is that the lines in the oral commissure is not a good judgment, because everybody is resting their chin on a chin rest, and therefore this area is sort of compressed. So you tend to get more lines in the oral commissure. So Vizia, I think it's good to just look at the improvement around the eyes and around the cheek area. But anyway, before, she's 67 years old, so somebody more matured with thinner skin, and actually her true age before treatment was 61. As I told you, she's pretty good, but after the treatment, again, we have made improvement again to her skin. So these are actually objectively measured with Vizia machine. So that's all I got to share. Thank you very much, everybody, for listening for so long, or end up to be 1 hour and a bit. So now it's just time for Q&A. Okay, so I'm going to stop sharing my screen. Ares, can you put on your mic so you can talk to me? Okay, there is some Q&A here. Let me go from the very top. From Susan Siegel. Are you checking their clotting and prothrombin gene status yourself before giving tranexamic acid orally? Clotting and prothrombin gene status yourself before giving tranexamic acid orally? No. I just asked them questions. Do they have clotting tendencies? Actually, tranexamic acid doesn't cause clotting. Tranexamic acid just prevents clots from being broken down. So what matters is, to me, is that if somebody has, say, valvular heart disease, where there's chance where they can form clots, then the tranexamic acid will prevent the dissolution of the clots, and that is one of the contraindications. Somebody have a history of DVT or other clotting issues. Those are contraindications for me. But generally, tranexamic acid doesn't increase clotting. It just prevents clot from breaking down. What protrusion? This is from Kevin Macarao. What protrusion do you use when treating melasma? What concentration of isopropyl alcohol do you use? Okay, thank you for that question. For treating melasma, I still use the same maximum, but just the dwell time is reduced to 6 usually, 8 at maximum. And then you can put your mesotherapy products that can lighten the skin if you want. You can use, some people use tranexamic acid. I have done it as well. It does help, but the things, whatever you put through the skin, the tranexamic acid is good for the first 2 weeks, but after that, your body use it up and there's no more on the skin. And that's why it's important to give it orally as well as a maintenance treatment. Usually within 2-3 treatments, once a month, most melasma will clear. In fact, I would say that in my case, 100% of the melasma cleared, I mean, not cleared, be reduced significantly if we do these 2 treatments. In fact, I would say also that if the so-called melasma doesn't improve with the treatment, then I will question my diagnosis. It's probably not melasma, but something else, okay? Because with this combination of tranexamic acid oral and Tixel at light setting, it reduces almost 100, I would say 100% of my melasma patients. Another question from Kevin. For aggressive treatment, 6 millisecond, what protrusion do you use? Okay, 6 millisecond is a very light treatment. It's not an aggressive treatment. So again, I will still use the maximum, so either 800 or 1000, depending on what machine you have. Another question from Kevin. What are your favorite mesotherapy products? I use the RRS product, which is pretty good. They have whitening substance. There is another one, is also just a vitamin C that I just put on the skin. That is pretty good as well. Susan Siegel asked, you use Vaseline and not 50-50. Yes, you can use 50-50 if you want to. I just find that 50-50 is a bit more messy, a bit more liquidy. Vaseline is just that much better and easy for the patient to buy and for me to buy. Whereas 50-50, I need to get the pharmacist to make for me. So yeah, you can use either. They're just as good. Kevin questioned again, aggressive ablation settings that I use. For aggressive, I'll use 14 millisecond, 2 passes, 3 passes, and then to make it even more severe, as I've shared with you, then we abrade the skin and then do another 8 or 10 millisecond, 1 or 2 more passes to create the dermal tightening. From Muntasa, can you send the record after finish because I missed too much from the meeting? I have too many patients, things like that. Yes, I think it will be put on YouTube so everybody can re-listen to this sharing. This is from Jerome. What about patient with a history of herpes? Very good questions. Sorry, I didn't put that in. I should have. Patient with herpes, obviously we tell them that there is no 100% guarantee that whatever we do to treat will stop the herpes from coming up. But we can reduce the severity or the chance of it coming up by giving anti-herpetic treatment. So my favorite is valacyclovir. So I will give 1,000 milligrams 24 hours before, and then another 1,000 milligram on the day itself. And that's it, just 2 doses. And that reduce, I mean, I hardly get any herpes flare-up, or maybe if they do, the patients don't care because it's just herpes anyway. But I do tell them that it is one of the possible thing that can happen, and there is no 100% suppressive treatment for it. From Kevin, for nurse treated, are you abrading between each pass? My nurses are a bit frightened, so they tend not to abrade the skin. Not after each pass. There's no point to do it after each pass, because the whole idea is to do 2 or 3 passes first, and therefore you create a lot more of the dermal epidermal junction break or vacuoles, so that the epidermis is loose, and after that, then you can actually easily wipe off the epidermis. Okay, if you do it after every pass, it's not an efficient use of the time. And also, if you need to cool it down with hypochlorous solution, then the next pass will be even less effective. So do 2-3 passes first before you abrade. This is from Mark Despinoa. Thank you for the great presentation. Could you tell more about treating the periorbital area and how you make sure it's safe for the eyes? The treatment is very safe for the eyes. It is non-radiating treatment, so it's not like laser or intense pulse light. It will not damage the eyes at all. You can go as close to the eyes as you want. In fact, as you know, Tixel now is used for treating dry eyes. So yeah, it's very, very safe for the eyes. No special precaution you need to do. What I do for the eyes, if I take off my glasses, is if I'm treating the bottom of the eyes, I ask the patient to actually look upwards that way, so I can then get as close to the eyelash as possible. And when I'm treating the top eyelid, then I ask the patient to close the eye, so then I can get the full access to the top eyelids. That's what I do. But Tixel is amazing for the eyes. If you want it to go even closer, then you get the little eye handpieces, so you can go closer to the brows. Okay, as long as you don't touch the eyes, obviously that is obvious, but otherwise there's no special precaution for treating the eyes. This is from Krena. Do you have experience with combo treatments, including Tixel and IPL on the same day? Do you have experience with Tixel followed by PRP? Okay, I'll answer the second one first. I'm not a believer in PRP, so I never do PRP. To me, there's no evidence that PRP does anything, so I just do Tixel. Tixel and IPL, I haven't done it, but why do I want to do it? That's the question, because Tixel will do what the IPL can do and probably better. And also worried that there could be too much heating if you do both treatment at the same time. So just do Tixel alone. If you do it properly, it is so powerful. You do not need any other devices treatment. Okay, IPL will be used full later on, maybe for rosacea patient with there's a lot of blood vessels, but Tixel alone will reduce that significantly, because rosacea is due to photo damage. So when you have new collagen formation, rosacea do get better. Some colleagues do put Botox after their Tixel poured onto the skin to reduce the erythema. I do that sometimes, but I can tell you that just Tixel alone for rosacea is also pretty good, okay, without even the use of the Botox. So how many pulses, this is from Susan again, how many pulses on average are you using for the more aggressive treatments? So Susan, one pass is about 300 to 350 pulses. So if I do 3 passes, there's about 900, about 800 pulses or so, because you don't repeat everywhere. That's for 3 passes, and then I abrade it, and then I'll do another 1 pass on certain areas that you want to go deeper, you want to see skin tightening. So it's not unusual for me to use about 1100 pulses per face, okay, when I'm doing that very severe treatment. This is from Claudio Diaz. What are you usually setting for the neck and the décolleté? For the neck and décolleté, I use maximum 12 millisecond. I don't use 14 millisecond. Again, the protrusion is always maximum, so I never talk about that anymore now. And I hope in the future, maybe Tixel can just set that as a standard maximum protrusion, because really there is no need for adjusting the protrusion, in my experience anyway. So for the neck and décolleté, it's 12 milliseconds. I don't go higher than that because areas outside the face has less sebaceous gland, so healing time is longer. I have tried 14 before, but as I said, the healing time is a lot longer. 12 is enough to get the result, and you can do two passes as well. I tend not to abrade around outside the face because there's again less sebaceous gland. So what I've told you about the abrasion and dermal tightening, that's only for the face, guys. Okay, not for outside the face. It's more dangerous. Fanny Renanda, how to prevent the complications. Yep, so to prevent the complication, the most common one is PIH, so just watch out for it. If somebody with darker skin types, use lower setting to prevent the infection. I spray with hypochlorous solution afterwards, and then seal the skin straight away with either the Cetaphil or Vaseline. And then tell the patient, don't use any other topicals on top of it, so you don't get the contact dermatitis, because these three is the only complications that I have seen. This is from Pascal. What is your Tixel protocol to lift up the upper eyelid? It's the same. As on lighter skin types, I do use 14 milliseconds, 2 passes at least, sometimes 3 passes. And then I can abrade it and then maybe apply another 8 milliseconds on top as well. If you want to do it all in one treatment, but most patients may not want that because they don't have downtime, then you can put lower setting, 10, 12 milliseconds, but do at least do 3 passes, okay? Because you need the density. Without the density, you will not get the lifting of the eyelids. Georgina Bannister, recommended setting for skin type 4 patients seeking rejuvenation, no skin prep, and only time for 1 treatment. Does not care how much downtime she has. Yep, so skin type 4, if they just want 1 treatment, again, you have to see how severe is the photo damage. But if there is no care for downtime and no care for PIH, then do what I did for that patient with skin type 6, 3 passes, abrade, another 1 or 2 passes at a lower setting. Okay, so you can get very nice tightening. Again, from Mark, thank you for the clear answer. I have a customer who is very interested in melasma treatment. Could you share detailed protocol? Yes, so very easy, Mark, for melasma, 6 to 8 milliseconds, 2-3 passes, and then you apply your favorite mesotherapy products with the lightening agents. And then after that, if there is no contraindication, you prescribe for them tranexamic acid. They come in 500 milligram tablet. So I ask the patient to halve it. So they take 250 and then they take it twice a day. So it's 1 tablet per day, basically. And then give it continuously for at least 3 months. But at 3 months, it's still only very light lightening. If you carry it on for a year, you can see there's a more significant lightening of the melasma. And then you only need to do 2 or 3 treatment with Tixel. And then if in the summer times when the melasmas worsen with the sun, ask them to come back for just 1 treatment once a month until they get less sun exposure again. So that's it, my treatment. This is from Kevin again, laser genesis from Qterra, followed by Tixel for full face. If you want to, just make sure the skin is cool enough before Tixel, because we don't want too much bulk hitting. So just make sure the skin is cooled down. But again, personally, it's not necessary. Obviously, probably the laser genesis is used for treating the vascular appearance on the skin. So you can do that if you want, but just make sure the skin is cool before you do the Tixel, okay? But there's no harm splitting the treatment and just asking the patient to come back at another time. Rosacea setting, depending on the type of rosacea and early rhinophyma. Well, the setting is not depending on the rosacea type, but it's more on the downtime of the patient that they can take. Again, the more aggressive the treatment is, the more new collagen formation you're going to get. the better the rosacea is going to get. Because if you look histologically, rosacea is very similar to photo damage. The collagen is very broken up. And therefore, I think there's less tensions around the blood vessel and you get this dilation of the blood vessel. So if you can produce more collagens in the epidermis, at least, there'll be somehow less dilation of the blood vessels and the rosacea to get better. That is my thinking about it, how I think Tixel works, or not even Tixel, even just any of the resurfacing treatment can work for rosacea. But that's just my own take on it. Okay. Rhinophyma, obviously you can use your cautery or the almond radiofrequency treatment to just slice off all the rhinophyma. Light rhinophyma, probably you can, I've never done this before, but I would imagine it'll be the same like the acne scars on that lady. You just need to do 3 passes, abrade it, and then tighten the dermis. Okay, but the nose is very forgiving, so it's one area that I'm not afraid to treat if such case do ever come to me. So that's all the Q&A I've got. Is there any more questions? If not, we'll stop the meeting now. Okay, thank you everybody for spending the time to listen to this talk. I hope you have learned something and that we can continue to share our knowledge on Tixel. I think it's a wonderful machine. To me, it has changed my practice quite considerably. I used to use a lot of CO2 laser, but now Tixel have taken over. I don't use CO2 anymore for resurfacing. For other use of CO2 like cutting and so on, I can use other devices. So I've actually sold my CO2 laser. So in my practice now, it's just for aesthetic neurotoxin, fillers, topical treatments, and Tixel, and that's it. And I can treat most cases just that way. Oh, I do have the element as well, radiofrequency for the blood vessels. Sometimes that I use. Okay, but that's all my machine. Okay, take care everybody. Thank you very much for listening. Bye.